Good afternoon, everyone. Welcome to FACTS webinar Wednesday. It's brought to you by FACTS Institute for County Government with support from UF IFAS. Today we begin a series of webcasts that are being held this week. Today's webcast addresses one of our least favorite but most important topics on COVID-19. However, we'll spin this in a more positive light as our presenter will be talking about vaccines and vaccine distribution. Just as some background, tomorrow at 2, we return to our best practices in county government program. And we'll be hosting Polk County, who will talk about their award-winning program known as Helping Hands, which is a successful jail transition program that the county's implemented. On Thursday, we have another webinar. We'll host one of our friends, Mr. Kurt Spitzer. He'll talk to us about redistricting issues and considerations and issues in light of the most recent census. But for today, we do want to return to COVID, but with a little more optimism. And I think even for the casual observer, they would take note that obviously vaccines are available. However, there are certainly a lot of questions about how the vaccine was developed, its effectiveness, who's been recommended to get the vaccine first, sort of the population that or populations that are a little bit reluctant to get vaccinated. And finally, and our presenter may not be able to answer this in full, but we do want to just have a conversation about what the overall distribution strategy looks like, or really what factors are currently involved in terms of the distribution plan and the distribution strategy, which I think for some has been a little bit foggy. So today I'm really happy to welcome Dr. Lee Washington. Dr. Washington is the Senior Medical Advisor of the Department of Plan and Science and Aetna National Accounts. Aetna is a part of CVS Health. And with that, Dr. Washington, welcome and thank you for joining us today.
My pleasure, and thank you, Eric, and thank you everyone who is attending this as well. I think this is a topic that I'm sure there's probably some fatigue that's developing as we've been talking about this for some time. But as Eric mentioned, I think what you're going to hear, and probably what you have been hearing on the news, has been a little more optimism, which makes it a little more palatable to continue to talk about this. And it is a rapidly evolving area. So some of these things will be answers that will be evolving over time. What I'm going to cover are 3 broad areas, and I'll just say provide a little context. You can see some of the names on the slides. Dr. Shagaturu heads up our effort at CVS and across the enterprise at CVS and Aetna, really, which is a team effort of physicians and other clinical experts throughout the organization to really bring the best information and the best approach to controlling the COVID pandemic to people like yourselves, large employers, populations that are trying to minimize the effect of COVID-19 on their employee workforce regarding their health and also their productivity. The 3 areas we're going to talk about today, I'm going to talk a little bit about the science of COVID-19. I've been warned not to talk too much about the science because that may not be what people want to focus on. So I'm just going to spend a little bit of time on that, which also is evolving. And then we'll talk a little about distribution and how that process is going. And then sort of the logistics of actually getting shots in arms, which, as you might imagine, when you're trying to vaccinate something north of several hundred million people in the state of Illinois, in the United States, that's not a small task, and billions of people worldwide. So this is a really major undertaking, unlike anything we've seen in recent years. So as we go through, we're going to talk about these things that I mentioned and what is some of the scientific information regarding coronavirus. Well, one of the things that's important to recognize is that this is a problem that has gotten attention in an unprecedented way. And you can see these different major pandemics or epidemics that have happened in the past, whether it's malaria, tuberculosis, Ebola, and you look at the vaccine candidates, and we've just had multiple vaccine candidates for COVID-19, by far more than any other major disease. And I would also add that we've seen the vaccine become available to the public after scientific validation in record time. The fastest vaccine in the past that's become available was measles in the 60s, took 4 years. This has actually happened about a year after this pandemic really started hitting the United States. We see vaccines available, and partly the reason for that is the maturing science, the RNA based vaccine science that has evolved based on genetics, and has truly allowed this to happen at a revolutionary pace without sacrificing effectiveness and safety. And so when we talk about the vaccine, there are, as you saw from the previous slide, several hundred that are, or a couple hundred that are in production. One of the things that they all, for the most part, have in common is that they target the spike protein of the COVID virus. And so the spike protein is that which allows the COVID virus to attach to the cell and cause an infection. And it is what is targeted by each of the vaccines. And when we talk about these different strains, the UK variant, the South African variant, and equally concerning, but not as talked about, the Brazilian variant, a lot of the variation is in the spike protein, which has raised some concerns about the vaccine effectiveness. Fortunately, what we have seen is the vaccine has remained effective, perhaps not as effective in some of the variants, but because of the high generation of protective antibody that this vaccine generates, it actually, even though it's not as effective, for example, in the South African variant, it still does prevent hospitalization and death based on studies that have been done so far very consistently. So, you know, this has been, again, a very rapid period of rolling out this vaccine. And we've talked about the candidates. What we're seeing in the United States for distribution right now are the Pfizer vaccine and the Moderna vaccine. And what we think is going to get emergency use authorization in the very near future is the Johnson & Johnson vaccine. The technology for those are a little different. I won't go into detail unless there's specific questions, but the Pfizer and the Moderna vaccine use an RNA technology. Johnson & Johnson uses more of a viral gene delivery methodology that's been used for other diseases like hemophilia, for example. And so, and we're going to see AstraZeneca, which uses a similar technology to Johnson & Johnson, and Novavax, which is a little different than all of the ones we mentioned. But this is, there are a number of vaccines around the world. These are just 4, 3 of which should be available. 2 are already available in the United States. The third one should be available very soon. So one of the big challenges that we have is vaccine hesitancy. This is where you really get into the dynamics of getting shots in arms. It's one thing to have the technology available. It's another thing to be able to get people to use it. And it's only effective if we only get to herd immunity if we can get a large number of folks vaccinated. And most experts say we need to get around 70 to 80% vaccinated. So if you look at the portion of people who are open or not open to the vaccine, you can see that there's this huge middle part of the population. They're uncertain, they want to wait. That's the part of the population that we think is most amenable to influence. So we want to communicate with them and get them to move. Now, what we've done at CVS is looked at how these patterns have emerged over time. What's a little bit disconcerting is that we've seen the numbers increase a little bit on the side of being disinclined for the vaccine. And there may be a number of reasons for that. There are some experiences that people have had where they've gotten the actual infection and then within 90 days gotten their first dose of the vaccine and had a severe reaction, specifically speaking to the Moderna, Pfizer vaccines. There's also been scenarios where the second dose of the vaccine has provoked some reaction. So this is something that we're going to see evolve over time, but one of the ways that we're trying to increase comfort level with the vaccine is encouraging people who are influencers to be very public about their decision to get vaccinated. And I think we're also seeing that, fortunately, there are a number of people who are who informally know people who have gotten vaccinated and how they've done. And that's going to play a big role in terms of getting this vaccine adopted more widely. Now, you can see with vaccine hesitancy, it varies significantly according to demographics. And you can see particularly you have higher levels of hesitancy in the African-American community, those who are definitely not going to get it or who are uncertain. And you can see you also have a significant number in the Hispanic and Native American populations as well. It's interesting also, this seems to also go based on political affiliation, with people who are more Republican being less trusting of the vaccine versus Democrat. So we see a number of different factors that are playing a role. But one of the things we want to continue to do is make sure that people have accurate information about the vaccine, which is one of the reasons why we're communicating information, sharing our perspective as we continue to play a role in vaccinating the country. One of the things that we've looked at are who are the key influencers that help to determine whether someone is hesitant or more likely to get the vaccine. And not unlike other areas of public health, you can see that overwhelmingly across all demographics, it's the person's own physician that is going to be the big driver of whether they want to get the vaccine or not. Certainly that varies some by population, and perhaps the disproportionately low number that's influenced by the physician in the Hispanic population is because of lack of a congruent language between the provider and the patient. But you can see for the most part, the physician, the individual's physician has more influence than Dr. Fauci or someone from the CDC or someone from the FDA. And as you go into the more political realm, whether it's the presidential task force, or even if it's a publication that the person respects, you can see the influence drops precipitously. So having that personal source of information is really important. So one of the ways that, there are multiple ways really that we're working to address vaccine hesitancy, and that includes reaching out to providers. One of the things we know about this vaccine is that there are a significant number of healthcare providers who have some hesitancy about the vaccine. Fortunately, we have seen those numbers move, where you have some providers, and in some cases in a very high profile way, who have expressed their change in opinion, where they were initially hesitant and now they're all in on the vaccine. So we do think that this is going to be influenced as we get more experience with the vaccine, as more people get it, and as that information is communicated to the public and information is shared. One of the things we'll talk about as we move to the distribution of the vaccine is how we're looking to strategically distribute the vaccine around the country. And one of the things that is important is distribution is critical, because if we had unlimited supply of vaccine, distribution would not be a critical issue. But what we know is that right now, as we're trying to ramp this process up, one of the major limitations in the ability to vaccinate is the supply. And so that is part of the reason why the CDC issued guidance, and starting with the most vulnerable populations and expanding. And so we'll talk more about that, but strategically distributing the vaccine is a really important part of dealing with supply issues. So from a distribution standpoint, one of the things that is really good about our system and our footprint in the country is that when you look at the location of our CVS stores and you look at those who have social vulnerability, and that could be based on income, that could be based on location, employment status, based on how rural the neighborhood is. But you can see we have a significant accessibility to those who have higher socioeconomic risks. So you can see the social vulnerability index very high. And you look at the percentage of folks who have access, it's a little higher as you go up the scale for people who are within 1 mile of a CVS location. It's a little higher when you go 2 miles. And it's really higher across the board, 5 miles, 10 miles, it's more even with the rest of the population. But I think this says that really it speaks to the idea that we are well positioned not only to contribute to vaccine distribution, but also vaccine equity. And that's a big part of the role that we are playing in South Florida, where we're looking to roll those vaccines out initially to populations that have been shown to be hardest hit by coronavirus. So that's going to be key. What's the experience for people getting an immunization? I think arguably more than any other service that we've talked about in a long time, patient experience is so important. It's not just important because you want people to come back for that second shot. You want them to go out and tell other people to get vaccinated to decrease vaccine hesitancy, but also having it done in an efficient way is really important, because you don't want to see what we've seen on the news in some cases, these nightmare scenarios where you have crowds and crowds of people standing around, crowded together, and potentially putting themselves at risk for contracting the coronavirus. We really want to make sure we have a smooth flow so that people are getting in, getting out, getting their shot, so that it's done on an appointment type basis, and we're not getting these huge crowds of people who just show up and are waiting. And so I think the fact that we have such a broad experience with flu vaccine, with other vaccines, and this is something that has been part of our core competency, we're able to do that in a way that people or systems that don't do that to the extent that we do may not. And so we have a number of locations. I talked a little bit about the footprint. We have a lot of clinicians and people who are skilled at administering the vaccine, administering it. And then we have a workflow that gets people in and out. We have online appointments, can be done through an iPhone. And the idea is we want this to be a seamless process so that people come in and that they come back when they get that second vaccination. So if you look at the US population within, did not mean to go to the next slide. Let me go back if I can, go back a couple slides. So if you look at the US population and the accessibility to a CVS, you can see that we have a footprint, a significant footprint across a lot of the country. There are some states where there's less penetration, some of the far Northeast, Alaska, some of the Western states, but for the most part, throughout the US, we have a really good footprint and very good accessibility, which is key, not just for vaccinations, but for a lot of health-related things that require in-person, but especially critical for vaccinations. So these are some of the vaccines that we've had campaigns for every year: influenza, pneumonia. Those are sort of your recurring ones. And you can see the spectrum here from very common to perhaps not as common, but still things that we do on a regular basis. And you can see the total number of vaccinations that we've given within a relatively short time period, 20 million in 2020. That's really something that is a part of our core competency, and doing that efficiently is probably more important with COVID-19 than it is for most infections or other reasons to get a vaccine. So, one of the things that's kind of important is that really making sure that we have a consistent way of doing things so that it's done properly, so that there's the right amount of education and training, and so that as the public comes in, again, there's that building that trust, that confidence level, and conveying accurate information is critical. So I'm going to move forward a little bit because I want to make sure we have plenty of time for questions. One of the things that does come up a lot is the phasing of vaccinations. And you can see that, we've played an enormous role in phase one, where you're talking about healthcare personnel, congregate facilities. We are one of two major retail chains that have played a role in really speeding up that distribution process and making sure that people get it. Many states are now beginning to enter into phase 1B, although where states are is widely variable around the country. And as we go into the broader population, you can see for phase 1C, 65 to 74-year-olds, people who are younger with high-risk medical conditions, and then eventually everyone who has not previously been vaccinated. What we're anticipating, and the conversation we're really encouraging with our plan sponsors and employers, is how can we help you as we move into these phases where there's more availability of the vaccine to the population at large. Things that we're exploring are providing an on-site vaccination clinic so that employees can get vaccinated right there at the workplace, not taking any significant amount of time from what they're doing, and making it seamless. We really want to make sure that it's really easy for anyone who wants a vaccine to be able to get one. The long-term care vaccination effort, as I mentioned, huge number of facilities around the country, a lot of residents. And what we're starting to see is that, and particularly in the United States, we're starting to see a gradual or significant decline in new cases of COVID-19. Most experts think it's too early to say whether this is a part of the vaccination effort or not, or a result of the vaccination effort. Could be a combination of things. But what we know from experience in other countries, notably Israel has vaccinated close to 50% of its population. We're starting to see data that not only does the vaccination prevent severe disease, but it also seems to drastically lower transmissibility, which is a huge piece of good news as we look to try to safely open things up in the economy in the near future. So this is something that there's been an ongoing partnership with our long-term care vaccination facility, and that's something that we think is making a significant impact on morbidity and mortality in that population. And we're going to just kind of go through to talk about some of the infrastructure that we have in place around vaccination. So there's a whole process where we have this really organized from A to Z in terms of how we get people appointments, get the appropriate consent forms done, and get them in and out for the facility. One of the things I would point to as an example of where we've played a role in this type of effort has been our massive rollout of COVID-19 testing. Certainly that's not the topic of this conversation, and it may come up. We don't think that the need for testing is going to go away right away, even with the optimism that we're talking about with the vaccine. But the point I want to make from this slide is that there's really an underlying process for getting this done efficiently. A lot of it behind the scenes, but critically important to being successful with this vaccination effort. So when we prepare to vaccinate the general population, you've heard different goals set by the Biden administration in terms of how many vaccinations they'd like to have. There's been, of course, complexities associated with weather and supply chain challenges. But we think that there's the potential for a capacity of this huge volume of vaccines per month, right? 25 million. And we think that the large footprint of the CVS pharmacy is going to be huge for the distribution of that process. I've talked a little bit about the whole notion of using the iPhone to get an appointment. And for those who have utilized the Minute Clinic for various things, I think most people would agree that that experience is a little easier in terms of in and out than even most physician offices. And we intend to leverage that type of experience, that type of workflow to enhance access to the vaccination. Things like email reminders. One of the things we know is it's really important that no doses of the vaccine go wasted in an environment where supply is right now what's limiting us. And so having a real seamless process for this is going to be critical. We have covered a lot of material, the idea behind logistics, getting shots in arms, and just touched on the science behind this. Given my background, I think my predilection would have been to spend a lot more time on that, but I can't look at the audience in this type of venue, so I can't see if you're sleeping. But I certainly am happy to take questions and go into any area that you'd like in more detail. So let me pause and see what questions there are.
Good. Dr. Washington, thank you. I'm not asleep. I'm wide awake. We got a number of questions, and I don't know if you're going to be able to answer all of them, but let's kind of try to work through this. Some of them are kind of basic. Some we've heard the news quite a bit. Can you just speak to the effectiveness of the current vaccine that's out right now?
Sure. So when we talk about the effectiveness of the vaccine, one of the things to keep in mind is the most common variant available in the United States in terms of the COVID-19, the most common variant that's being spread in the United States. What the expected future variant, which is expected to be the most common variant, is expected to be the UK variant. And by the way, a lot of times they try to get away from using the place of origin as the identifier for the variant because people no country really wants to be associated with that. But just for ease of communication, I'm going to do that here. So you think of the UK variant, by sometime in March, that's projected to be the most common variant. For those who may not know, about 50 to 70% more infectious than the most common variant preceding that, and potentially about 30% more lethal, so very significant. But I think what has people concerned more than the UK variant is the South African variant, which has a number of mutations in the spike protein. You may remember that's the protein that drives the infection and the invasion into the cell. So just real quickly then, from the standpoint of effectiveness, when you're looking at the UK variant and the other commonly circulating variants in the US, the effectiveness as measured by both clinical response and the level of antibodies specific to the virus is very high. It's very well targeted for those types of variants to the virus. Now, when you move to the South African variant, the effectiveness drops by about 50%. So significantly less effective. The antibody is significantly less targeted to the South African variant. But a key point is that because the amount of antibody that's generated is so much higher than what's needed to provide immunity to the other variants, even though it drops significantly for the South African variant, it has still been shown to prevent severe disease, hospitalization, and death in the South African variant. So it's still very effective against the South African variant. Now, the data on the Johnson & Johnson, so I'm specifically talking about the vaccines that are available now, Moderna and Pfizer. With the Johnson & Johnson vaccine, that perhaps was a little less effective against the South African variant, but still was 100% so far, based on the data we have, 100% effective for preventing hospitalization as well as death. So right now, we believe we have vaccines that are very effective against the commonly circulating variants out there. A couple caveats: there are other variants that are forming and that have formed. In Brazil, there's a Brazilian variant that was responsible in a town that tried to go the herd immunity strategy by natural immunity. So you had really high infections in this town in Manaus, Brazil. When this Brazilian variant came into that town, it reinfected the majority of the population, even though over 70% had antibodies from previous infection, and it caused an overwhelming crisis in the healthcare system there. So these variants are something that we're keeping a close eye on. Tentative information suggests that if the Brazilian variant comes here, it will be susceptible, probably to about the same degree as the South African variant. So right now, we think we have vaccines that are going to take care of all the common variants. There is also work being done on the platforms to be able to modify the vaccine quickly if there's a variant that's found that it's not susceptible to. And that's something that we're going to have to constantly be vigilant about for probably into the foreseeable future, even after things are really fully and safely opened up.
Yeah, that last statement you just answered my follow-up question. Can we talk about the those that are hesitant to take this vaccine? Are you seeing the numbers in terms of percentage of those populations that are hesitant similar to those that are hesitant to take an annual flu shot, for example?
Yeah, no, that's a great question. And so I have not seen comparative head-to-head data between the two, but we do know every year there are a lot of people who don't get the flu shot. Typically, the sense is that the consequences of not getting it are probably, unless you're a person working in a facility, a congregate facility for the elderly, in which case you may be mandated to get the flu vaccine, right? Unless you're in that category, there probably aren't dramatic consequences in most cases, as there might be for not getting the coronavirus vaccine. But so we haven't seen the educational campaigns, the social media campaigns done for the flu vaccine like for the corona vaccine. But if I were to just take a guess, I would guess that the hesitancy is probably similar, but just a lot less attention is paid to the flu vaccine because it hasn't devastated the country like coronavirus has.
The media and social media appear to be a double-edged sword, because what you don't really get to hear are really the efficacy of those that have taken the first and second shot, and they're, hopefully are going to be able to withstand this. But you did mention that there have been some that have responded negatively even on a first or second shot, and that's what usually gets played out in the media. And so I think that feeds the reluctance of those. Can you talk about whether or not the science community is tracking data on those individuals who responded negatively, and what were some of the underlying conditions that led to that?
Yeah, no, absolutely. That's a really important question. And so with any vaccine, there is a vaccine adverse event reporting system, VAERS, that is used to track adverse events to the vaccine. So that would also be the case for coronavirus. But to your point, because coronavirus, the whole issue of vaccine hesitancy is such a big one, we've been, and I think a lot of organizations have been looking really closely at what's coming up as we go through these vaccination campaigns. And one theme that comes out of that is that if you have pre-existing antibody to the virus, to the spike protein, when you get that vaccine, you're getting a boost in that. Some people seem to tolerate that perfectly fine without having any type of adverse event. And then there's some people who seem to get a more severe reaction. So what we've seen is a lot of discomfort in terms of perhaps arm pain, inflammation. we haven't seen anything that approaches what some of the more severe complications from coronavirus are, but we have seen some adverse reactions that create enough discomfort that it has undoubtedly contributed to some people's hesitancy to get a second vaccine. For example, there's a city that we work with where they had really high rates, city out east, really high rates of coronavirus infection. And when we started the vaccination campaign in that city, there were a certain number of people who got vaccinated after within a 90-day period of an infection of coronavirus. And what we found is that a sample of that group did get severe reactions, swelling, pain. It was a bad enough experience that they said they probably would not come back for a second vaccination. And so those situations we do have, that is actually being studied by University of Massachusetts at Amherst out there to really try to get a handle on what's happening in those cases. But also we've heard of adverse events related to discomfort associated with the second of the two vaccinations. And again, discomfort, not anything that I've come across that indicates that it's a severe and lasting complication, but discomfort, physical discomfort is certainly a deterrent, and we have seen that in some cases with the corona vaccine. The other thing I'll just mention is that with medicine, I think what's been unrecognized is that there's always a certain amount of uncertainty in medicine, and usually, unfortunately, there's a widespread perception that medicine is an exact science when it really isn't. And so I think one of the things that we as healthcare professionals have to do when addressing vaccine hesitancy is make sure that we put the information on the table and that we're frank about what we know and what we don't know. And I think the coronavirus has really created an atmosphere where that type of transparency is important.
What happens if someone just decides to get one shot? Are they at least 50% in better
Yeah.
shape?
That's what the data suggests at this point, that with a single shot of the Pfizer Moderna vaccine, that confers about 50% protection. I don't think we have enough data to say whether that means you won't have hospitalization or death. Certainly the clinical trials were done with two shots. And it is important to keep in mind that if Johnson & Johnson is approved, which we think is going to happen, if not in February, sometime in early March, that would be one shot, different mechanism than the Pfizer or Moderna vaccines. It uses a gene carrier virus, one that's been done many times before. We have a good deal of confidence in the reliability of that technology. So that's another vaccine that'll be available that will provide the option for just one shot.
Dr. Watson, we got a series of questions that I don't know if you're going to be comfortable answering just because you might not be familiar with it, but I think it's the series of questions that a lot of the community wants to know, and certainly our counties want to know. And it really goes back just to the development of the vaccine with respect to government support and funding for that. I've heard, on National Public Radio, different stories about how the government decided to go ahead and buy or at least provide advance funding for some of the companies. Can you talk just a little bit about what the federal government's role has been in that to date and how that's helping accelerate the vaccine?
Sure, I'm happy to talk some about that. And I would say that, perhaps my line of sight is not as direct as some other information you might get. But what I will say is that having heard from a number of manufacturers, that there are some manufacturers who have said out front that these are more like your very large companies, that they said out front they didn't need the government funding. They wanted to fund it themselves. They believed in what they were doing, and they wanted to have complete freedom to go about it in the way that they thought was best, and did not want to take any potential encumbrances that might come along with federal funding. But I think other companies have been funded. And one of the things that's really important to recognize is that just like with what I said about uncertainty in medicine, federal subsidies for pharmaceutical companies to try to deal with what's perceived or what is in fact an urgent public health crisis is not anything new. So now the way that funding comes can vary. For example, when we look at rare diseases, that's increasingly being funded indirectly through the federal government by having certain protections regarding patents and other things like that, which so it doesn't have to be a dollar changing hands to mean that federal policy hasn't played a role in funding it. And fundamentally, one of the issues we have with pharma is that if you're a smaller pharmaceutical company, you're challenged in developing whether it's breakthrough therapies or a vaccine that could theoretically be given to billions of people. You're challenged by that upfront investment, and usually what typically is a very rigorous review process where there's a huge upfront expense to getting a drug on the market and a certain amount of uncertainty as to whether that drug will ultimately get approved and recoup any of that expense. So that's the fundamental issue that government funding is designed to address. And so when we talk about 213 vaccine candidates for coronavirus, when you look at these smaller companies that are getting their vaccine onto the marketplace, that doesn't happen without typically federal funding is a critical part of enabling that to happen. And when you talk about returning to normal, there have been a number of analyses. Some of them have quite frankly proven wrong as we've gotten more experience, but the general concept has proven to be correct. The more vaccines that you have approved that you can get onto the marketplace, the quicker we return to normal. At one time, several months ago, there was a projection that you needed 6 vaccines on the market to return to normal by August. That model was probably a little wrong, but certainly having 3 or 4 vaccines is a lot better than having 1 vaccine when you're talking about vaccinating your entire adult population.
Is that just because of capacity issue in terms of being able to generate it?
That is because of capacity. That's correct.
Okay. So again, this is a question that you may not be able to answer, and it deals with the distribution. And so clearly, you showed in your slides if CVS gets the vaccine, you have the capacity, the logistics, the community outreach to get that vaccine distributed. But from our perspective, and I think a lot in the public, is it's kind of a mystery box because there are, and correct me if I'm wrong, and maybe you can help explain this, that there seems to be a number of distributors. Okay, so I understand that some hospitals may get a distribution, a primary care physician may get a distribution. At one point, the federal government was using CVS for long-term care facilities. All I know is that the state of Florida gets on a Monday what the full allotment they're going to get for the state. And then it's kind of parsed up. They don't get to really assign where it's distributed. No one has really been able, in my opinion, to be able to say to the public, all right, here's how the distribution is going to go out logistically and where it's going to go. If you read the papers in Florida, you've seen where the state has done a couple of things. And it almost seems to change on a weekly basis. So does the federal government, the CDC, have a role in any of that? Or it just seems to me that, quote unquote, the plan is something that gets made up on a weekly basis based on how much of the vaccine's available?
Right. So, the perspective I would share based on what we've seen is that you sort of have the guidance that's put out there by the CDC, right? So you have the 1A, 1B, et cetera, and defining the highest risk populations and prioritizing them for the vaccine. But then at the state level, you have a lot of flexibility in terms of whether you decide to follow the CDC guidelines or modify them in some ways. And what we've seen is that the variation in terms of the priorities is what we see changing from state to state or varying from state to state. So my perception has always been that the states are ultimately deciding upon their priorities and then going about it that way. I will say that, so I've been educated about through my contact with people in Florida, the Florida market, and was told that if you Google Florida man, you get some interesting things on your Google search. So I'll just say that one of the stories that was shared with me recently is that there were 2 Florida young ladies who were in their 30s and who decided that they wanted to get the vaccine, but they were not old enough to get that vaccine. And personally, given my own age, I was a little insulted by this because I'm told that they put on bonnets and covered their heads with hoods, which to me, that sounds like a very outmoded style of dress, even for the age I can more identify with. But it's one of the few times where Florida woman actually got the spotlight over Florida man. So I wanted to share that. But to answer your question, I really think it's more at the state level where there's variance there, not so much at the federal. That's been my perspective.
Yeah, usually the Florida Man article deals with a Florida guy swimming with an alligator or something silly
Right,
like that. But I did see the Florida women one.
Okay.
There's a question that came through the chat, and it just says, it asks, what actions can communities do to encourage those that are hesitant to take the vaccine? I know in one of your slides you had a phrase in there that's it's called culturally competent education. I don't know if you're able to elaborate on that, but any response to that question?
No, I think that's a really important question. And we've seen a number of things happening with, so really, if you think back to this slide and that I showed where it showed the influencers, and the top influencer based on what we've surveyed has been the individual physician for that patient. Patients tend to listen to their doctors, and then you go down a level and you've got your public figures like Dr. Anthony Fauci and others, the CDC. And so I think really the opportunity is to educate physicians, and I think I would extend that to also educating members. So we know that vaccine hesitancy does exist in the medical community, and we see at least anecdotal stories of that starting to change as people get more information. So I think we have to share information. And if someone is an influencer, so if they're a physician getting vaccinated, it's almost a waste not to put that on social media if they're willing to do that, because that's going to speak volumes to people who look to them for information in terms of getting vaccinated. And we see a lot of that happening. I was just on a panel discussion with one of the UIC emergency room physicians, and when she got her vaccine, she was very diligent about making sure it got posted to social media, and probably had influence on other people getting vaccinated that we won't know about necessarily, but hopefully will show up as we get closer to that herd immunity.
I got just probably one or two last questions. The first one is a Dr. Fauci question.
Sure.
If you can answer it, just with respect to, the term was flattening the curve, and we all learned what that meant early on. But the fact that, the country's shut down, and now everyone's wearing masks, and that seems to be the norm. What is your sense for, has that helped? Is there science that shows that, hey, we did not go out for several months, and at least in Florida, you can go out just about anywhere and do anything, I think, because of people just are fatigued. But what is your sense for the effectiveness of what we've done?
Yeah, no, I think that's a great question. And so there are a certain number of cities that throughout the country where you have data before and after a mask mandate, or you have data where there was a mask mandate in some counties and no mask mandate in others. And what we've seen is a significant flattening of the curve, or even reversal of the curve in terms of new infections that correlates with the mask mandates. And when you compare those to similar counties without a mask mandate, you see that curve continuing to go up in terms of new infections. The other thing that I'll say is that with certain countries that have been more strict in terms of social distancing, mask mandates, et cetera, we've seen dramatic differences in death rates as well as infection rates in those countries compared to others that have not been as strict. So there's a lot of empiric and epidemiologic evidence to indicate that mask wearing, and I guess the new term isn't social distancing, but physical distancing, since we have things like Zoom and other things to communicate with each other. But that physical distancing and mask mandates do make a big difference. And they're going to be, that's going to be important even after the vaccine, until we know that we've gotten herd immunity. And even after that, we're going to have to still do epidemiologic tracing, so that if there is an outbreak in some countries, we can jump on it, do the social distancing, find out what's happened, so that we can control it before it spreads throughout the country. I'll just say real quick, in Taiwan, they had very strict social distancing, admittedly, much smaller country, around 22, 23 million, but they had strict social distancing and masks. And they went 200 days while we were in the midst of this epidemic. They went 200 days without a single infection. But to the point of ongoing vigilance, after 200 days with no community acquired infection, they had a spike. And they were able to isolate that spike. Everybody else in the country continued to do their usual thing, but that small population where that spike occurred, they instituted social distancing masks, et cetera, and until that got quelled. When you have to lock down an entire country, the results, I don't have to tell you, are just absolutely devastating economically. So we really need to think in terms of virus control and economic activity, not one or the other, because that's a false choice. And we've got epidemiologic evidence to prove that.
Yeah, I mean, to me, the hassle was worth the potential reward. So I had no trouble wearing a mask and shutting down. I guess we're going to wrap up, and I'm going to ask you to look in your crystal ball, if you could, as a scientist. What do you see in the next 6 to 12 months?
Yeah, so I think where we started this talk was on the whole idea of optimism, right? And so I think you're spot on when you say that this is a time, really since the start of the pandemic, I've heard more things that are cause for optimism than I have during this entire time period. So what it looks like is going to happen is that as we get more people vaccinated, even before we get to herd immunity, we're likely to see a significant reduction in new infections, which is really positive. And as we get more people vaccinated, hopefully that will have a domino effect in moving the needle with regards to others' opinions who are hesitant now, who may go on and get vaccinated. And so, it's not out of the realm of possibility that by the summer or fall, we will start to see more of an ability to safely open. Although I suspect that there will be a new normal where, you have some opening, but you still have masks and you still have some degree of physical distancing. But I think we will be able to increasingly move away from these lockdowns that will be proportionate with more and more people getting vaccinated. And one of the biggest pieces of optimism is the evidence that's starting to emerge, and it hasn't been confirmed yet. So we have to wait until we actually get some studies confirming this. But the evidence is starting to emerge that people who get vaccinated are less likely, significantly less likely to transmit the virus as compared to people who don't. If that evidence holds, that's going to be extremely favorable. And so as we move into this new normal, I think you're going to still have a need for some social distancing, some masks, and some testing, so that if there is an outbreak, it can be controlled locally. But I think we can, within the next year, move this from being a pandemic or even an epidemic to being more endemic to certain areas where there's a problem or a hotspot in a given area that we have to address. And that's all going to be dependent on whether we are able and willing to invest in that public health infrastructure for the ongoing monitoring.
All right, let's end on that optimism. And all I really want to do is go to a ball game. I don't care the sport. I just kind of want to get out there.
Yeah,
so
sure.
Dr. Washington, thanks for your time today. Appreciate it. This is, even though I said this is my least favorite topic, it's one we've had to bring on many times, and I know we're going to address it again in the months to come. But thank you for coming on, and appreciate the partnership that we have with Aetna. So I wish you well. Thank you.
My pleasure. Great talking with you.